You're listening to Chest Pulse. This podcast is a non-promotional, non-CME educational program brought to you by Chest in collaboration with GSK. And now, here's your host, Dr. Anju Peters.
Welcome to Chest Pulse. I'm Dr. Anju Peters, and joining me to discuss the challenges, gaps, and opportunities in diagnosing and managing refractory chronic cough, or RCC, is Dr. Michael Blaise and Dr. Michael Gabriel. Welcome to the program.
Thank you, Dr. Peters.
Thanks, Dr. Peters, for having us.
Perfect. Let's get started. The first question, let's address this to Dr. Michael Blaise. What is refractory chronic cough, and why is it important for healthcare workers such as pulmonologists, allergists, those of us who take care of patients with chronic cough to understand this condition?
So I think the best way to define refractory chronic cough is that it is a chronic cough. And again, by our definition, that means a cough that's been going on for greater than 8 weeks, where in fact one has done an extensive workup, ruled out the major causes for a chronic cough, and yet the patient, even maybe after empiric treatment, is in fact continuing to have cough. So it gets to be primarily a diagnosis of exclusion. We know that most of these patients have a high level of neuronal hypersensitivity associated with their condition.
Well, thank you so much for telling us about refractory chronic cough. Dr. Gabriel, anything else to add?
It's basically this condition that's been going on for years. Patients are coming so frustrated, affected many aspects in their life, socially, physically, and emotionally, affected their marriage, their relationships, their social activities. And definitely, these patients are quite frustrated. So we are dealing with a condition that patients are going around in the community with chronic symptoms and questions that's been going on for so long without being answered.
I think you guys both hit the point that this has been going on for a long time. It is a significant negative impact on patients' quality of life. It affects their physical, psychological, and social aspects of daily living. Let's move on to question number 2. And Dr. Gabriel, let's start with you. Recently, there was a CHEST GSK survey done where CHEST Analytics initially conducted a focus group with community and academic pulmonologists at the CHEST meeting in Boston during October 2024. The findings of those focus groups then led to a survey which was administered to pulmonologists from the CHEST Analytics database during May of 2025. This survey revealed some really interesting facts about refractory chronic cough, and this was recently published, I guess, on the CHEST website. Can you tell us a little bit more about the patient journey that we found out from this CHEST GSK survey?
Of course, it's a great survey, and one of the surveys that kind of highlight the gaps and the missing parts and how hard this patient's journey has been. It showed us that more than 70% of referrals to pulmonologists are coming from primary care. And these patients, most of the time, have seen at least 2 providers before being seen or referred to a pulmonologist. Referral to pulmonologists, once it occurs, pulmonologists are more likely to take more of a systemic approach in regards of ruling out certain diagnoses and managing these patients in a step approach to kind of find out what's causing this, and they take most of the time the lead in following up these patients in regards to chronic cough. It also showed us that referral to chronic cough clinics or chronic cough centers is quite low. It's probably less than 5% of the patients are being referred to chronic cough centers where patients are being evaluated by more than one provider, maybe in a multidisciplinary approach to try to get to the origin and the etiology of the chronic cough. Even when patients are being referred, pulmonologists sometimes can not ask patients or probe certain complaints like globus sensation or miss certain parts of the chronic cough evaluation, like patient's technique of using treatments, what kind of treatments they have used in the past, and what kind of impact, like an anxiety, depression, fatigue, urinary incontinence, that patients can have in association with chronic cough or as a consequence of chronic cough. So it's really highlighted how patient's journey takes place, how pulmonologists would take the lead, and what kind of tests or treatments they may ask patients to follow, but also what kind of gaps that occur because of lack of more of a standardized guidelines and standardized approach.
Yeah, thank you so much. And just to again, this is a clinical perspective paper that is on the CHEST website if anyone wants to see the results more in detail, as well as the methodology. Um, Dr. Michael One, Dr. Blaise, anything else you'd like to add that the survey revealed about the patient journey?
Yeah, I think Michael too covered it extremely well, and I think emphasized that we just don't have enough of these chronic cough clinics, for all the patients that are suffering with this condition. And another aspect I think from this is that many times it's hard for patients, in fact, to get referrals. So there's a lot more we need to do to help these patients and shorten their journey to diagnosis.
Yeah, thank you again both for sharing. Let's move on to the next question, which is where do you see the biggest gaps in diagnosis of refractory chronic cough? Dr. Blaise, let's start with you, and then we'll go to Dr. Gabriel.
So, unfortunately, there were a lot of gaps here, which I think leads to a lot of the problems of getting to a quick diagnosis. I mean, part of it's just failure for a timely workup. We know this, we talk about chronic cough starting at greater than 8 weeks, but we see patients that have had no workup, for literally months or years after that 8 week period. So just, the length of time there. I think their problem out there for a lot of clinicians don't realize that, in fact, this is a distinct condition. This is a disease, refractory chronic cough. Another big problem is that there is no standard biomarker or test that we can quickly make that diagnosis. So again, as I mentioned before, it becomes a diagnosis of exclusion. And then I don't think most of the physicians out there, follow a structured diagnostic algorithm to help them as far as making sure they follow the steps to determine, in fact, if that patient has refractory chronic cough.
Thanks so much. Dr. Gabriel, anything you'd like to add about the biggest gaps in diagnosis?
Yeah, 100% agree with Dr. Blaise. So from my perspective, seeing these patients on daily basis, one gap is there is time seeing these patients and providing them with listening and validation to their symptoms. So these patients oftentimes report that they haven't been heard before, they weren't able to express their symptoms as they used during their visit. Two is like more objective tools to assess patients' current symptoms and patients' response to treatment. How are we doing, and how can we get these patients to follow-ups at short intervals to know whether they are doing well or they are actually having side effects from treatment. Three is we need really more updated guidelines where we are all talking the same language, identifying the problem, as Dr. Blaise has said, that it's a distinct problem, and how we can identify it and treat it in a more uniform, standardized fashion, not just a try and error kind of thing.
Yeah, thank you. For those just tuning in, you're listening to Chest Pulse. I'm Dr. Anju Peters, and today I'm speaking with Dr. Michael Blaise and Dr. Michael Gabriel about the findings of a national survey on refractory chronic cough and how they can inform better diagnosis and treatment. So let's keep moving. And one of the things that we should make clear is that there are no FDA-approved medications for refractory chronic cough. We do have guidelines both from Europe as well as US, the CHEST guidelines, that tell us how to diagnose these patients, what to consider in terms of workup and potential treatments. So let's start with you, Dr. Gabriel. How are pulmonologists currently managing refractory chronic cough, and what are the main challenges?
So the current management really depends on identifying an etiology or going mainly in a systematic approach to kind of get patients some answers. oftentimes when we do all the workup and we tried so many different interventions targeting treatment for these patients, we are not being successful. And that's what gets us to the refractory chronic cough, sometimes unexplained chronic cough that we try to refrain from using the terminology. But most common treatments that have patients already started before seeing us are just the over-the-counter antitussive medications, benzonatate. These were approved way in the past. They work more primarily for acute and subacute cough, but they really don't work so very well for patients with chronic cough. Another agents that we often use off-label, as you mentioned, there is no currently FDA-approved medications for refractory chronic cough. So everything we are using now are off-label, and we discuss with patients mechanism of action, benefits, risks. These don't come risk-free, but oftentimes we use neuromodulators, medications that kind of work on the cough reflex to decrease patient sensitivity, so they aren't necessarily being stimulated by stimuli that are not necessarily causing cough for regular people. We definitely have to take this in conjunction with behavioral therapy and speech language pathology to help patients achieve best outcomes. That's what the studies have shown patients would benefit from.
Yeah. Let's move on actually to question 5, unless Dr. Blaise, you wanted to address anything in terms of currently managing RCC.
No, I think the allergy community, has the same approach. Again, we have no products at this point in time, medications that are FDA approved. So using off-label neuromodulators, using speech and language therapists to help with these patients tends to be the most common treatment regimen that we're doing at this time in these patient population.
Yeah, I have to agree with you. And, I just think all of us working together, ENTs, GIs, pulmonologists, allergists, speech language therapists, to see how we can best treat this chronic vexing problem. So let's move to the next question. And Dr. Blaise, I'll address this to you first. What are the key opportunities to improve patient care for RCC?
Well, I think first of all, we all need to realize that, in fact, again, this is a disease. We need to have better standard workup protocols for these patients, in many cases, faster referrals, and better education out there where there's a great deal of just a lack of awareness. We can look at using the cough assessment tools that we have, whether we talk about visual analog scales, their quality of life scales. Hopefully, in the future, we'll have some of these emerging therapies. There are several interesting things in the pipeline, like P2X3 receptor antagonist, which block the effect of ATP signaling, which can trigger cough. There's also work going on opiate receptor modulators, these kappa agonist, mu antagonists that centrally work. Again, studies are ongoing, so hopefully in the future we may have these types of treatments. And I think we also need to educate primary care more about this condition. They should really be starting the initiation of the workup and to be able to fast track these patients. So again, we get this patient journey down to a few months instead of, in many cases, years before the diagnosis is made.
Dr. Gabriel, what do you think are the key opportunities to improve patient care for RCC?
Quite hard to follow what Dr. Blaise has just mentioned. It's basically that's what we are lacking, and that's what we are missing. We need diagnostic tests and assessment tools, a standardized approach, and we need treatments that really work and are safe for patients.
Thank you very much, Dr. Gabriel. And I want to thank both of you, Dr. Michael Blaise, Dr. Michael Gabriel, for joining me in today's discussion. There's significant unmet need and understanding in managing refractory chronic cough. And you have shared some highlights with us about this important survey that's on the CHEST website. It was great speaking with you today. Thanks for listening to Chest Pulse.
Thank you for having me.
Thank you.
You were listening to Chest Pulse. This podcast is a non-promotional, non-CME educational program brought to you by Chest in collaboration with GSK.